so I'm just going to focus on the renal pathology side of it, for what we know to date. But even before there were reports of kidney injury, people were hypothesizing that there would be, an element of kidney injury, or that the kidney might be directly affected because of the ACE2 protein, and it's known to be expressed in the kidney. So the kind of initial reports that were coming out from the clinical perspective, were obviously from Wuhan, but and in the interpretation of all these studies, obviously you have to keep in mind that there is a selection bias. You're looking at a lot of, especially the initial reports were the severe end of the spectrum autopsy studies based on so people who actually died of COVID. So the manifestation that they have from a kidney point of view may not necessarily be a spectrum that milder people have, but or it could be true. Maybe milder cases have the same findings but at a milder level, but there could be different pathologies as well. And then obviously there's the age and comorbidity factors that play into it. Then people die at various illnesses, or phases of the illness. So people, older people tended to die younger. Younger people survive to get ARDS, and or ventilated. So you may see a different spectrum based on age, based on you may see a different pathology spectrum as well. And then obviously you have things like reporting bias. So from China, there's a possibility that there may have been some systemic bias in the system, or government influencing reporting and things. So I think that when it comes to the clinical data related to how common is AKI, how severe is it, then I think that the New York data so far is the most reliable. I'm sure there probably is some good data on its way from the UK as well, but I just haven't seen it yet in publications. But from the original Wuhan kind of study, they just reported 300 cases, and they were saying that there's a very high rate of AKI. Particularly there was a lot of proteinuria and hematuria on dipstick. Now, but when you look at the grades of AKI with the KDIGO stages, their severe end of spectrum was quite low. So obviously there was some inherent bias, whether it's that old people weren't making it to hospital or weren't. There's lots of things that could have contributed to that, but they did report early on that there was hematuria and proteinuria were common. Now, in none of the reports that I've seen, they have they, apart from the glomerulonephritis cases, have they looked to see was the proteinuria albuminuria or was it tubular protein? So often you'll see with bad tubular injury, you get some spillage of tubular protein in the urine. You will get some amount of proteinuria when you check, but unless it's albuminuria, you're not fully sure if it's glomerular or not. But when you're looking, so the New York, this is impressed. It may have come out in the last couple of days, but a couple of days ago it was still it's a pre-proof, but this is the largest case series. So that's from the Mount Sinai. So there's two groups in New York that published, the Mount Sinai group and then the Hofstra group. So the Mount Sinai is the the Hofstra group actually in total is a bigger cohort, but the Mount Sinai one is 3,200. So they reported their AKI rate overall. So this is hospitalized patients. So 3,200 hospitalized people with COVID in the New York Mount Sinai system. So that roughly their rate of AKI was overall 43%. And like it's been reported elsewhere, there did seem to be a disproportionate, the Black Afro-Caribbean and African Americans seem to be disproportionately affected. And obviously teasing that apart from socioeconomic things and everything is always difficult, but particularly in America. But so the same pattern seems to play out. African American race, comorbidities like diabetes mellitus, congestive heart failure, hypertension, and peripheral vascular disease. And obviously CKD was a risk factor for AKI due to COVID. Then when they looked at the stages of AKI, so there does seem to be a relationship between how unwell you are from COVID in general, how bad your pneumonitis is, and how bad your kidney injury is. So the more unwell you are from other manifestations of COVID, the more likely you're to have kidney injury, and the more likely you're to have severe end of kidney injury scale. So when they looked at ICU admissions, obviously the kind of stage 3 AKI stage, KDIGO stage, and dialysis were more common than those who didn't end up being admitted. And then they looked at recovery. So some people are starting to commentate on CKD due to COVID, but in my opinion, I think it's a bit premature, because the only reports I've seen are just until hospital discharge. So there is a proportion of people who get a bad AKI that hasn't recovered fully by the time they're discharged. A lot of them do become independent of dialysis, but they probably still have a high creatinine before the discharge. But anyone who's worked in the American system will see, they'll know as well that your discharge there is not the same as discharge here. People are sent home or they're sent to a skilled nursing facility. They're not, they're not. They may not be sent directly to home, but they're sent out of hospital, quicker than we would do here. So, but there does seem to be, severe acute kidney injury that can be in certain individuals prolonged, and the recovery, at least up until a few weeks post admission, the recovery is not very it's not like you would see with a typical sepsis ATN. But then you have to factor into that the system's overwhelmed in New York. The healthcare resources are overwhelmed. There's lots of reasons why things may turn out like that. Well, yeah, just before I put it in there because I didn't want to forget that, so Barbara Murphy is obviously Irish nephrologist who's the chair of medicine in Mount Sinai, and she did make a comment that, so they're working on this is the pre-proof of the initial paper, but then they're also working on the autopsy series from these people. And she did comment that they mainly saw acute tubular injury, so they didn't see the degree of, lots of people as well have kind of commentating about in the literature with perspectives and things that, is this a renal limited TMA or systemic TMA? And so we'll talk about that in a while in the Wuhan autopsy series, but she commented that from the New York system, it will be published, but they didn't see a huge amount of renal limited thrombotic microangiopathy. So this, I'm going to skip through this because it's the same thing basically, but it's just the Hofstra group. So within New York as well, 5,000 cases, they saw a similar rate of overall AKI, about 40%, and a kind of mostly mild, but then 30% were severe. They didn't really look at recovery in that paper at the time of writing. So then, you look at the literature, there's lots of reports coming. So originally there was no autopsy series and everyone was waiting for, the autopsy series to see what exactly is happening in the kidney in these cases. And then we got the Wuhan one. But since then, there's been lots of autopsy series, particularly since the virus has hit America. So, but a lot of them focus mainly on the lungs. So they don't really report what's happened in the kidneys. So this is one example where they just really reported that, so the people in this series died of bronchopneumonia from COVID, or there was a lot of coexisting pulmonary embolism. But the series was only, I think, 12 cases. But the most common kidney abnormalities they saw were cysts and atherosclerosis, but that's, an age-related factor. So obviously the people who are dying of COVID are older, you're seeing more cysts and vascular disease within the kidney. They did have one 54-year-old lady who had kidney infarctions, but they didn't delve into that more to see what was the cause. Was it cardioembolic? What was the actual cause? But that's the only case that I came across with actually kidney infarctions. So the thrombophilia associated with COVID, you hear lots of reports, even from our, colleagues working clinically in the ICU, that there just seemed to be a lot of thrombosis. And, there was that one study from New York that was published in JACC where they looked at 1,000 cases, and those who were on systemic, full dose, treatment dose tinzaparin or low molecular heparin had a lower mortality. But obviously there's lots of confounding there. It was an observational study. But from the autopsy series, it doesn't seem to be a prominent feature in other organs like the kidney in particular anyway. So there is, pulmonary embolism is very common in these cases who had autopsy. There is reports, so this is another one from Italy that didn't describe what happened in the kidneys, but they did find a lot of arterial thrombi in 33 out of 38 cases who died of COVID pneumonitis. So these were like small fibrin thrombi in the arterioles in the lung. And this is the thing that people are struggling with. The pulmonologists and intensives are trying to figure out what is the cause of the hypoxia that seems to be disproportionate or not like other cases. But we don't, in all the autopsy series to date, this hasn't been reported, this thrombi of small arterial vessels, apart from a couple of thrombi in the glomerulus, in a couple of cases, which we'll talk about. But so then we go on to the Wuhan, the original series, the autopsy series. So 26 cases who died of COVID pneumonitis, the main feature they found was acute tubular injury. But they also reported these red cell aggregates in the peritubular capillaries. So again, a lot of people jump to the kind of conclusion that it's the same thing as in the lung, that this is a renal limited TMA. But when you read the paper in full, actually, most of the red cell aggregates didn't have platelet or fibrin in them, so they weren't exactly thrombi. Now, there was 3 cases where there were thrombi in the glomerulus, but these red cell aggregates, and then Agnes Fogel, who's a very well known pathologist, she's a co-author on this, and her take on that was that it's probably a hypoperfusion thing, and you do see that in autopsy series of people who die of cardiorenal syndrome, cardiogenic shock, or hemorrhagic shock. You see this red cell aggregation in the tubules, and it's thought to be due to slowish blood flow. So in that, so her take on this was that this is probably mainly slowish intrarenal blood flow. Sorry. So then moving on, so then they also reported obviously the electron microscopy, where they could see structures that look like the virus, so look like COVID-19. And then they also went further to stain or detect an antibody against the nuclear protein and see did it stain within the kidney of these people. So the take home kind of that everyone took from that was, yes, there's a lot of direct infection in the kidney. It causes tubular injury, and that probably is, so direct infection of the podocyte is probably what causes the proteinuria. But when you actually look at the case series itself, each case, so the most common thing was acute tubular injury from mild to severe. But so fibrin thrombi in the glomerulus, there was actually only 3 cases within those 26 cases. And then they did see a lot of, so the coronavirus particles that they thought they saw, was probably in about 10 of the 26 or 8 of the 26, but a lot of the time they didn't see it. And when they stained for the antibody, only a couple of cases actually were positive. So there seems like there is definitely direct viral infection, but it may not be there in all cases, and it may not be the cause of the tubular injury always. So this is just these samples just show tubular injury here, the flattening of the lining, and then some. This is vacuolization of the tubules. Now they don't really talk about it in this series, but a later series looked more into this, and what they found was the areas of tubular injury that had vacuolization is where that corresponded to where the virus was also picked up on electron microscopy, whereas opposed to the tubular injury that didn't have the vacuolization didn't seem to have the virus present on EM. So they just reported a few other things. It's pigment casts, so there was rhabdomyolysis was occurred in a couple of cases, and they had some concomitant bacterial infections in a few cases as well. But so these are the thrombi that they actually saw. So there's a glomerular thrombi here in that figure G. And then in H, this is a collapsed glomerulus from hypoperfusion. So in theory that the blood flow was shut off by these thrombi. Sorry, that's the pigment cast there in E, the rhabdocast. So there were, fibrin thrombi with platelets in 3 cases out of the 26, but the red cell aggregates was more common. Actually, that's what this is showing here, sorry. So the vacuolization, and then these here are the red cell aggregates in the peritubular capillaries. So that was common, but it wasn't associated with fibrin and platelets, but there were a couple of lesions that did have the actual fibrin thrombi. So this is just a closer look at the EM, so the A there is the proximal tubule. So the A and B are the tubules. C is they're showing that they thought they could see the virus in podocyte foot processes as well. And so they felt like at the time that the EM appearance of these viruses is very suggestive of coronavirus. So the typical appearance, they call it like a crown-like appearance, and then in terms of the size in nanometers, it matches up. So then they went on to just this stain again was just to prove that there's no platelet and fibrin associated with the red cell aggregates, so they were just red blood cells by themselves. They went on then to look at just the ACE2 expression. So as we said, proximal tubule in particular, and there is some staining in the podocyte, but this was kind of the clincher for me that there is direct viral infection, at least in a subset of cases. So they stained for the SARS-CoV nucleoprotein, and so this is the proximal tubule, and then this is the podocyte. So there's less staining in the podocyte than the tubules, but there is staining. Then there was a couple of cases from Switzerland where they reported in the Lancet that they found endotheliitis. So they found direct invasion of endothelial cells by COVID-19 as well. So they reported in the kidney, and then also this is in the intima of a smooth muscle in a small artery in the small bowel. So a person presented with small bowel ischemia, and the resection showed COVID-19 in the intima of the blood vessel, and then this is just a pneumocyte. People wrote letters as well about suggesting that these structures that are seen on EM are not necessarily virus, that they could be these multivesicular bodies that are, non-specific and have thought to have multiple functions. And other people thought that they were probably clathrin-coated vesicles. But these guys in Switzerland didn't really prove it with antibody detection, but in Wuhan, this for me is more suggestive, the series from Wuhan. But then,
Bill, can I ask you, did they have lots of normal kidney, showing that this is specific?
They had a kidney control, yeah. They did in the Wuhan. I didn't put the slide.
A single kidney.
Yeah. So.
Sorry, it's fair, just to interject, it's fair to say that some people who've tried replicating using the same staining have not found that it worked. So a couple of the case reports where they've tried to look for the virus, they've used the same kit and they haven't been able to show it. So I think the EM stuff is probably the most convincing rather than the immuno.
Okay. So then we move on to, so there's obviously, the virus may behave. There was a suggestion that the virus virulence may be changing as it moves out of China, that, mutations, will it act the same in other populations? But this is a series from Germany where they looked at the tropism for the kidney. Now, so on the left here, this is basically just the association of viremia with organ tropism. So they didn't, in this report, I think they had just 22 cases, yeah. The degree of viremia didn't kind of seem to match up with the number of organs affected. But they did find, so they looked then for COVID RNA within the lung and kidney with the in situ hybridization, and it was positive in these cases. So 3 out of the 6, so they only did this in 6 people out of these 22. And they found it in 3 of the 6. They found RNA, and then when they stained with immunofluorescence again for the COVID-19 protein, they found a positive result again in podocytes and tubules. But again, that was 3 of 6 of the 22. Then we move on to Michigan. So they had a case where they reported in JSON where a man had an aortic dissection, was going to theater for emergency repair, then developed respiratory failure from COVID post-op, and eventually died of bronchopneumonia. Now, they found, this is the group that looked at, so this is the toluene blue staining, where they matching up the areas of vacuolization with the EM presence of the virus versus not. So this is the case where they suggested that perhaps vacuolization might be a good marker of direct viral infection of the kidney versus not in cases of tubular injury. So these were the areas that were matched up with that. So that again, the viral particles. So that they were in the tubules basically. Yeah. So they just were again talking about the ultrastructural feature, structure and appearance of the virus on the EM, matching up to reports of how this virus looks under the same method. then we have the Seattle experience. So a lot of this is kind of repetition, but it shows the kind of consistency of findings in the autopsies. But so they reported. So this is in press as well. I think it might be pre-proof. So it's not fully peer reviewed. So reported 12 cases, the usual age breakdown and male sex breakdown. But again, it's all EM finding, like you say, and in these other cases, EM suggestive of direct viral infection. And consistently in the tubules and to a lesser extent in the podocytes. But then another group came out from Wuhan with more cases. Again, this is in press, where they reported the same kind of findings. So tubular injury, ATN, but they went a bit further just to try and stain the tissue. So they looked for the antigen, viral NP antigen. And they found it detected in a number of cases within this 12. Now, yeah, I don't know if anyone has replicated this elsewhere, but they again found the EM structures as expected. They went a bit further and then started to stain for membrane attack complex. And so they, in their report, they suggested, the areas of vascularization that then link up with the EM finding of the virus, that also appears to line up with macrophage presence, so the CD68 macrophage present, and also with the membrane attack complex positivity. So in their series, the tubular injury and the degree appeared to line up with the intensity of C5b to 9 staining and the presence of macrophage and CD68. So maybe these will be useful markers going forward. I mean, you do see reports of people trying to use eculizumab as well, in addition to, or as an alternative to teclistamab in severe COVID. But so then there's one case then as well that I found where it's antemortem. So the person had a severe acute kidney injury, ended up on dialysis with COVID-19 infection and had a biopsy. But this person just had tubular injury, so didn't have any ultrastructural findings on EM of viral infection. But this person actually, it looked like they had cardiorenal syndrome really they had myocarditis from COVID. So their ATN was probably more linked to cytokine storm or pre-renal cardiorenal syndrome. So they didn't find the virus. So there is a spectrum of disease in this condition. So the other thing that strikes me as well is, particularly with the use of teclistamab, is that there is an analogous situation with kidney injury due to cytokine storm, right? So for years, the literature would always talk about, sepsis AKI, ATN is a portion of it due to cytokines, and could those cytokines be removed with CRT and cytosorb and different membranes? But I never fully believed the old sepsis ATN thing in cytokine storm, but until when you look at CAR T cells, so hopefully CAR T cells will be coming to St. James's soon. But when you look at so whether or not a direct cytokine storm can directly affect kidney injury and cause acute tubular injury in ATN, I think the best evidence that that's true is from studies of CAR T cells, so for people who don't really know, so for the treatment of different hematological disorders, but mainly for lymphoma, so people's T cells are removed with leukapheresis, then you get, so they're altered then with the insertion of a chimeric receptor antigen. So basically, if you can imagine the lymphoma being CD20 positive, so you would basically engineer T cells to attack those cells and set them up with the specific markers to hunt down these lymphoma cells and lyse them. But that is well known to cause a cytokine release syndrome that manifests in a similar way. So it can cause lung injury, so ARDS, it can cause cardiomyopathy, and in the kidney, it can cause acute tubular injury directly. So there's this is a case series from Mass General where they had 60 cases. But the most common cause of the AKI there was pre-renal AKI related to third spacing. So either third spacing from cytokines, or else a cardiorenal phenomenon where you get a direct cardiomyopathy as a result of the release of cytokines. that leads to reduced kidney perfusion. So most cases of those cases responded to measures to treat those, but the prognosis is very poor if you get cardiac involvement. But there isn't. It seems analogous to to a portion of cases with COVID where you get the HLH syndrome with intense inflammation and cytokines. So the cytokines themselves could be causing some of the tubular injury, and the use of teclistamab. So teclistamab became, fundamental in the treatment of cytokine release syndrome and prevention for CAR T cells. So there's an analogous situation there too, where now teclistamab is being used for HLH in COVID-19 severe infection. So we're just going to move on to the glomerulopathies that are reported with COVID. So I'm just going to go through one. So there's 4 that I could see in the literature yet, but Professor Salam has a case as well, I think, or a couple of them maybe, in London. But this is just one case from Switzerland, where 63-year-old black man developed. So he developed COVID, then got a severe AKI and ended up on dialysis. They biopsied him, and the findings were pretty impressive. So he had severe collapsing FSGS and superimposed tubular injury without any kind of significant inflammation. And the immunofluorescence didn't show any immune deposits. And they looked for, actually, with RT-PCR for SARS within the frozen sample and didn't find it. But the electron microscopy did look like it did look like the virus was present. So this is just, the collapsing lesion, collapsing FSGS, and it's here now. Yes, these reabsorption droplets suggesting that there's severe nephrosis with proteinuria that the tubes are trying to compensate and reabsorb. So within the podocyte and the foot processes, they found these structures that look very like COVID-19. And he was known to have systemic COVID himself and pneumonitis, but so there was no antigen test, but there was electron microscopy and severe nephrotic syndrome. So there was no specific treatment given for that. So again, you see the crown-like appearance and the spikes. That person wasn't given any specific treatment, just supportive treatment. And the kidney, the nephrotic syndrome improved, but didn't resolve completely. So the kidney function improved. At the time of writing, he still had about 2 grams of proteinuria and creatinine, a very high creatinine, about 400 by our standard. So there's a couple of other cases in Maryland. There's another one reported from New Orleans in KR reports. And so this is a good review article. So the slides will be available if people want to just more of a kind of a dossier of what's out there now, but it's changing rapidly. There's lots of reports coming out. But that's a pretty good review article, but it's outdated by now. So that report's kind of the first 3 or 4 studies, but I think that group came from the journal club, the Twitter journal club, FJC. But so to summarize, AKI in COVID appears to involve a complex process. So it's driven by virus-mediated injury. So the other thing is that there's lots of hypotheses about why they're getting so much thrombosis in the pulmonary vasculature. But one of the prevailing theories is endotheliitis, so direct viral infection of the endothelium. But again, like we don't really see that. I haven't seen a lot of that in these autopsy series in the kidney. So there's a combination of things, probably virus-mediated injury, cytokine storm, activation of angiotensin pathway, hypotension with reduced perfusion, possibly some dysregulation of complement. The hypercoagulation and microangiopathy is probably a bit oversold, I think, based on so it definitely in a small subset is there. There's something happening there, but it doesn't seem to be the most common thing as the cause of AKI. And of course, this is all superimposed on mostly on known vascular risk factors and CKD as well. So that's just a kind of a diagrammatic summary. So I just put these, we always have to be careful. Their autopsy series, there's only a couple of biopsies, small for the amount of the population actually infected. The case reports are still very small, so we should be careful not to generalize to all the cases of COVID kidney. there is a notable absence of interstitial nephritis. So, most viral infections that we see, CMV, adenovirus, BK, there's an element of interstitial nephritis, lymphocytic nephritis, but that's not being reported so far in the case reports. And there's obviously heterogeneity in pathology due to rate of infection, the degree of overwhelming health services, race, comorbidity, and age. And like I said, it depends. What you find at autopsy will obviously depend on what stage the person died at. So younger people tend to survive longer into the course, older people die younger. So kind of repeating the same topics there. So summary, mostly so the AKI due to COVID seems to mostly be tubular injury. There's definitely an element of direct viral infection in some cases, maybe not all. Perhaps the vacuolization might be a clue to direct viral infection. And as Professor Salama said, the electron microscopy is a good way of also looking. There is probably a cytokine storm element in some cases due to, so ATN, in my view, I didn't really believe it as much before with the sepsis literature, but the cytokine storm from CAR T cells where you have no infection, there's and you have a very temporal relationship between the cytokine release and ATN. So I do believe it now. And there's probably a cardiorenal element as well, and third spacing. We're still not sure. The proteinuria that's report has been very common in the AKI. We're not sure if that's tubular protein or albuminuria or a mix. The renal TMA, in my view, is oversold, and we don't have any, apart from one case in literature so far, there's no real signs of direct renal thrombosis, or multiple large parts of the kidney being thrombosed. And the last bit is that, I think the COVID CKD is probably a bit premature at the moment because the case series, the follow-up period isn't that long. It's basically until hospital discharge. So whether or not these people will fully recover or end up with CKD is not known. I mean, we have personally looked after a couple that have fully recovered who had bad AKIs and James's, but time will tell when these more observation periods, probably from the New York series, because they have a large number of cases. And thanks very much.
Thanks very much, Donal. I hope you all could hear and see it. We are recording this anyway, so you'll have it online afterwards for those who couldn't make it. So I'd like to open it to the floor. Anybody, any comments or insights, questions? I guess the kind of main thing is that I'm pretty convinced, moderately convinced, that there seems to be viral infection in the kidney. As to whether that's actually causing pathology or not, I don't know. Anybody else got any thoughts or questions?
Can I just say a couple of, that was really nice. A couple of things that we've seen here. We've seen some just tying in with the expression of the ACE2 protein in the different parts of the kidney. We've seen some good going Fanconi syndrome. I can show you a very quick case summary of that. And we've seen one case of a nephrogenic DI that's developed in somebody who had previously had a stroke and so was very dependent on some PEG feeding, and developed a nephrogenic DI about a week after he had tested positive for COVID. So tubular injury is very common. In fact, if I just as you were speaking, I was just trying to pull this up. I'm going to share. I'm going to see if I can share this with you just for a second. Sorry to. So this was a transplant patient we had. Can you guys see that?
Yeah.
This was a transplant patient we had who was diabetic, who was in the hospital for an amputation because she had gangrene in her foot. Who developed COVID or caught COVID nosocomially while she was here. And you can see that we hadn't been measuring her bicarb when she was in the hospital, but she presented at that point with a bicarb after COVID of 4 with a phosphate of 0.18 and a potassium of 2.9. And just speaking to Donal's point about the proteinuria, she had a urinary retinol binding protein of 1,540 milligrams, so 1.5 grams of proteinuria, but all low molecular weight proteinuria and no albuminuria. So I think you're absolutely right. A lot of the protein that has been reported on dipstick in the early Chinese series, about 40% of them, I think a lot of it is tubular proteinuria and it's not actually albuminuria. And then she was treated with replacement therapy, and you can see that eventually things settled down. Although interestingly, as she had her bicarbonate corrected, she ended up with a more profound hypokalemia, which you sometimes see because she wastes more bicarbonate, and so with that comes out the potassium. But at the peak of her tubular injury, she had a sort of fractional excretion of phosphate near 40% and a massive fractional excretion of potassium when she was being given that. And I'll just show you the DI case. He presented with a sodium of 152, low urinary sodium, a creatinine, an acute kidney injury, and a urine that was not able to concentrate properly in the face of holding on to salt and water as much as possible. And again, started a few days after the COVID and took quite a long time to resolve. So it is taking a few weeks before that gets better.
The only ADPL, have you?
No, he basically just had, I think part of the reason why he presented is that he wasn't able to drink more. I think probably this goes unnoticed in some people with COVID, but because they can just upregulate their drinking, they don't get themselves to this situation. He was dependent on fixed peg feeding, and so that as that wasn't increased, his free water loss meant that he became hypernatremic.
Yeah, and there's a lot of talk about people being quite volume depleted by the time they reach.
Yeah, so I think it's gone both ways. So the first, when there was a lot of AKI that was reported, everyone said, oh, this is because everyone is drying people out with diuretics because they're so worried about the lungs and they're so worried about needing ventilation. But I mean, I don't know what you think. I think it's pretty hard to really give somebody a severe AKI by giving them, 80 milligrams of freezer med. I think they've got to have multiple fluid losses plus diuretic to really get that sort of AKI.
So I'm just wondering whether they have, a superimposed on that subtle DI.
Yeah, I mean, it's possible. It's definitely possible. I mean, we're looking at the moment, we had a month where we had a sort of fluid restrictive bundle through casualty where people were trying to give diuretics and restrict fluid. And then when we realized that might not be such a good idea, we changed it. We're just analyzing the instance of AKI pre and post change in our fluid policy. So we'll be able to tell whether that's made a difference or not.
Interesting to see perhaps what their presentation sodium is.
Yeah. The other thing to say, which Donald spoke about in the collapsing GN, which is very interesting. There's an interesting paper from France that shows that type 1 interferons in some people who have very low levels, very severe COVID, are somehow impaired. And as a result of that, through upregulation of NF-kappa B, you get a lot of production of IL-6 and IL-1. And we have seen before COVID, BC, we saw a few people who had collapsing glomerulopathy in the context of HLH, which we know is associated with a macrophage producing cytokine, overproduction of cytokines, where you get a lot of IL-1. And they respond very well to anakinra, to IL-1 blockade. So it's interesting that it seems that there's two in terms of some of the people who get a very severe COVID get this high level of IL-1, which can be associated with a collapsing GN. But the patients that have been described in the literature have mostly been African or African origin, African American or Afro-Caribbean, and I think maybe two of them have actually had their APOL1 genes assayed and had the risk genotype. So whether at-risk genotype, the more the COVID induces something different or just brings it out, like parvo does or HIV does, whereas in most other people, it's actually an overexpression of IL-1, and as a result of not having enough type 1 interferons. So kind of either too much or too little IL-1, which might be inducing a sort of GN in those few patients. But your point is really well made that these are very, very small numbers of patients. And when we looked at the PM findings, our pathologist said, actually, this is the sort of thing you'll find from PM studies. You get tubular injury and it's not very specific. And it really doesn't tell you very much else.
And any interferon signatures on the EM, Donald, you know? Tubular reticular structures and stuff like that?
I don't know. No, I think that was the letter to the editors were proposing as that might be one of the mechanisms, but no, I don't think so. I haven't looked at all the collapsing one. I haven't looked at all of those in detail. I just presented that one. So it might be in the
one of them had a tubular reticular inclusion, and they suggested no other virus that was at least responsible. So it could have been COVID or it could have been something else. Of course, it kind of teaches us that maybe some of the things we didn't really understand before, which is when you get tubular reticular inclusions and they weren't HIV positive or didn't have lupus. And we said, well, what is this? We don't know. I mean, maybe it was a coronavirus of some description, because we certainly know that MERS and SARS had a similar tubular phenotype. And at least one report previously that suggested maybe it got into the podocyte. So COVID might be telling us a lot about diseases that we thought we knew about from before, but we didn't really understand.
Comments or questions from the SPR group? Silent SPR group.
Can I ask, is there anything different from the BK versus CMV or adeno for they cause an interstitial nephritis phenotype versus what's different with them regarding than COVID-19 that causes more so a direct tubular injury, or is it known?
I don't think it's known, as far as I know. It seems to be lymphocytic infiltration to react to those viruses, but causing, like I said, it's a lymphocytic interstitial nephritis. But now whether it's something to do with the fact again that it's post-mortem and for a lot of the cases, the virus seemed to be like tubular injury and the virus was sitting there, but there wasn't a lymphocytic infiltration. Yeah, so maybe it's just the time they died. Maybe I'm not sure. I don't think it's known though.
Yeah, I mean, I guess they are DNA viruses, which might make a difference. So the Matter crew have got a question there. They're just wondering if anybody's been re-biopsied after recovery. Are there still COVID particles present?
I haven't seen any case where I'm sure, things are changing quickly. There's lots of people, and everybody is, finding a niche to publish. So there probably will be some cases, but I haven't seen any so far.
Any other comments? We've got a kind of a huge slew of really intelligent people in Beaumont who are remaining silent.
Did the degree of AKI or the clinical phenotype correlate with the autopsy findings in the Chinese study? Don't know.
Is it again to the degree of which?
So did they talk about how severe was the AKI in relation to the autopsy findings from that study in Wuhan?
They found that so the severity of AKI correlated well with the severity of the overall COVID infection and the pneumonitis, but not with the level of viral infection, because they only confirmed it by EM and say the antibodies to nuclear protein in a small portion of that 26 cases. So a lot of them were negative for it. Yeah. But maybe, like you say, if you delved down enough into the electron abnormalities, Fanconi's, signs, maybe that would link more with the presence of the virus, but they didn't report that stuff.
I think a lot of that is not being picked up, to be honest. I think you have, some of these people on ITU are hypophosphatemic, and I don't know what your ITU is like, but I'm sure it's the same. They're very algorithmic, so they'll see a low phosphate. It might be because they're not eating. It might be because they're sick. It might be, so they'll just replace the phosphate. They won't necessarily think about where that phosphate loss is coming from. So I think some of the Fanconi's are being missed. I don't think there's been a very good assessment of proteinuria, as you say, and really very little kind of thought has been put on that. The ones we've looked at have certainly shown that mostly it's tubular, which would fit with what we know about the virus tropism. And I think the other important thing, as you said, is that some of these people may not have mounted a decent immune response to the virus, which is why they died. And of course, if they, there are no immune complexes in the kidney that have been shown so far. But in the ones who do mount a good immune response, who clear it, we've got a handful, not very many. I know some of the other London hospitals have got more who have got persistent dialysis-dependent kidney injury post-recovery from COVID, post-ITU, and some of those patients are being biopsied. So I think in the next week or two, we'll kind of know whether there is a persistent signal, whether there's an immune response to it, and that's why they're getting a sort of a problem as a result of it, or whether it's just persisting AKI, acute tubular injury that just hangs around for a bit longer.
Yeah, that's interesting. Yeah.
Okay, guys, any more comments before we move on to Professor Salama? If not, Alan, I'll hand over to you. And
okay, thank you. So what I was hoping to do was, so first, two things to say. First of all, you have to participate in this bit, otherwise it becomes really boring and I might hang up. The second thing is, rather than going through a topic and just kind of sort of showing you some slides on that, I thought we would try and approach some of this through case-based discussions, because it kind of highlights a lot of the things that need discussing anyway. Some of them might be more straightforward for you than others, and I'm sure none of them are all that challenging, but it's really, the interesting bit is the discussion around it and what it kind of leads us to. So with that preamble, let me just see if I can do this. So I'm hoping you can now see a screen. Yeah.
Yeah.
Let me just move your beautiful faces to one side. Okay, so so these are all cases whose names have been changed to keep their anonymity, obviously. So case one is a 71-year-old man who came in with breathlessness and some swelling over the preceding 2 months. Ischemic heart disease and hypertension. In the past, came in with dipstick positive protein, and then you can see the results there. His total protein of 60, albumin of 20, cholesterol of 8, and a creatinine of 250. And a PCR of 1200, and what immunology we had back. So, pretty straightforward. What do we think the differential is, and what else would you do? And I'll show you some pathology in a second, and you'll tell me what it shows. So differential, this is kind of bread and butter.
so Ayanfi, do you want to have a go at that? I'm going to pick on you guys if you don't.
Okay, can you hear me?
Yeah.
Yeah. So 71-year-old man with nephrotic. I didn't see his albumin. Sorry.
Low.
Low. Okay. So 71-year-old man with nephrotic syndrome. So differentials for that would be membranous nephropathy, membranous GN, minimal change, and FSGS. I would rank that membranous, FSGS, and minimal change. Yeah, those are my top 3.
Okay, so that's good. But what about the creatinine of 250?
What is there any chronicity on that? Do we have a previous baseline?
Okay. So that's a good question. So in fact, 6 months earlier, he had a creatinine of 80.
Okay.
Does that change your opinion about what the likely diagnosis is?
Yes. So more thinking towards possible myeloma, and was other light chain disease. So
Okay, so this proteinemic disease.
and,
What? But that wasn't one of your top 4 causes of nephrotic syndrome, right?
yeah, well, it wasn't top 3, but it should have been 4th. Yeah.
Should have been. Okay, but okay. What? Any of your top 3?
Yeah.
Any of your top 3 associated with AKI?
Not unless membranous. Not on, but you'd have to have lots of. So you have 12 grams of protein. You'd have to have lots of well, probably longer standing membranous to have an AKI.
Okay, so let me.
Not yeah.
So it's 2020. What do you do in terms of investigations?
Should we move that on to Beaumont, perhaps? Give Amphi a break.
Thank you.
Thank you, Amphi. Beaumont, you're up.
I mean, there's no trick here. This is kind of meant to be a gentle discussion. No one's going to get.
Okay, so we're all very shy here. Apologies. So we like to do further immunology and some antibody testing, including an anti-PLA2R antibody looking for primary membranous. We can't test for thrombospondin, I don't think, but potentially could do that. We'd also like to get an SPR serum-free light chain. I guess check that he's not diabetic, but it's unlikely given the progression of it and the fact that he's got full-on nephrotic syndrome. Clinically, he is 110 on 70. Is that what you said his blood pressure was?
Yep.
So I think that's what we'd like to do initially.
Okay, so just so I got it right, an anti-PLA2R, you said, protein electrophoresis and a immunoglobulins.
Yeah, and a serum-free light chain.
Serum-free light chain.
HbA1c, and then essentially we're going to want a biopsy anyway.
So, okay, I don't know how quickly you get your PLA2R back in Dublin, but we don't get ours probably for about 10 days or 2 weeks sometimes. So slightly difficult to decide what to do with him waiting on that. So, so we're going to proceed to a biopsy. Is that all right? Anyone disagree with that?
Yeah, we get there pretty quick here, so we go ahead with that.
Go ahead with that. Okay, so here we go. Here's the biopsy. So I don't. I'll give you a second to have a look at it. And then I don't know if anyone wants to, and I'll give you, let me see one more. Here we go. Here's a structure you'll all recognize.
I should mention that if you're on a touch screen, you can kind of pinch and enlarge it and all that kind of stuff.
Oh, can you? All right.
Yeah.
So anyone want to just have a crack at that? Tell me what you think it might show. So here's the low power, and here's a high power of the glomerulus. So we've got 2 things that we've got to explain, right? We've got to explain the nephrotic syndrome, and we've got to explain the acute kidney injury.
Dr. O'Keefe, you up first?
So on the low-powered one, it doesn't look too bad. Maybe there's some tubular injury, which might be due to the high degree of proteinuria. And then the glomerulus, I couldn't see anything dramatically abnormal, so maybe you're thinking more of a minimal change.
Okay.
On CV fluorescence.
Okay. Anything else on the high power? Just, I think that's very good, basically, Hannah. So let me show you just one other high power section. What do you think? What's that show?
Is it TAM horseful protein or protein within the tubule?
Yeah, so it's a granular cast, right? So it's a tubular granular cast, which is essentially made up of the. Can you see my arrow if I point or not? You can.
Yeah.
So this is degenerate tubular cells that have fallen off. I mean, if you look here, you can see segments of the tubular cells where the nuclei have actually disappeared. So these cells have fallen off the basement membrane and have formed a granular cast in the middle of the tubular lumen. So if you look carefully at the low power and you get your eye in, what you can see is that the tubules are very widely spaced apart. They're not nicely back to back, so there's some edema there. You can see they have got these granular casts in them, and you can see there are many tubules where there are segments where you don't see the nuclei properly. So they've got, and the tubules are enlarged, and some of the tubular walls are flattened. So this is quite severe tubular injury and normal looking glomeruli. So by definition, minimal change to the glomeruli. What do you want to do next? What's my next slide?
You'd like to see the EM?
Beautiful. So the EM is, and what are we looking for on the EM?
Podocyte effacement?
Yeah, so very severe podocyte injury, so flattening of the podocytes. You can see very flattened podocytes, very little nice elongated foot processes. So this is minimal change disease and acute tubular injury. And the reason for the acute kidney injury is not because there's anything wrong with the glomeruli, but because there is some very severe tubular damage that has caused this. And if you look, I'll come back to the management in a second. If you look at, there are a couple of very old series that have looked at AKI in the context of minimal change disease. And what you find is that, first of all, you can get it a number of weeks after the nephrotic syndrome begins, and it can last for a very long period of time. So the tubules take some time to regenerate. And in the ones who, if you compare patients who have an AKI with the ones who don't have an AKI with minimal change, you find that the AKI is often in the older patients who have worse hypertension, who have more proteinuria, and have got vessels that are normally less compliant. They've got more atherosclerotic vessels in their kidney, and they tend to have much more of a severe acute tubular injury. And some of them actually do need dialysis to get them over this for a period of time. And you often see as their renal function improves and they start to come off dialysis and their urine output increases, their proteinuria temporarily goes up again. So it sort of settles down a little bit as their urine output tails off and their renal function goes down. And as their renal function improves and their clearance increases, their proteinuria increases. And so, I mean, just not to labor the point, but treatment is conventionally with high-dose steroids, as you know. There's a new study that came out earlier on this year that compared a sort of randomized trial comparing tacrolimus with steroids that showed they were equally efficacious, and there's the visual abstract there. And that, at least in kids, there's reasonable good evidence that rituximab therapy is good for patients who have relapsing minimal change disease, and there are anecdotal reports in adults of the same. So steroids, CNIs. The one thing just to remember about minimal change disease, which I don't know that we often emphasize, certainly I don't think we tell patients quite that often, is that there's a massive relapse rate in the first year. So data from Columbia, data from this very small study, but large cohort series show that about 3/4 of adults will have at least one relapse within a year of treatment of their nephrotic syndrome due to minimal change disease. So they often require a second course or either a reintroduction or a re-escalation of their steroids when they have their relapse. Okay, everyone happy with that? So podocyte damage, minimal change disease, and coexistent tubular injury. The other things that you would think of with kidney injury and nephrotic syndrome, although I take your point exactly that the timing was a bit wrong, but think about diabetes, think about amyloid, think about myeloma, and think about membranous. They would be an FSGS. So all those other conditions causing nephrotic syndrome can be associated with renal impairment, although it's generally, as you say, much more a chronic condition rather than an acute change. Okay, if everyone's happy with that, I will move on. Oh, sorry. So there's a, yes, that's fine. Just remember sometimes that on the light microscopy, you can miss an early membranous. And so if the patients aren't responding to steroids or to, I mean, CNIs become a bit harder, but if they don't respond to steroids in the first instance in the way you might expect, just rethink that diagnosis, because you might actually have somebody who's got membranous and you might need to rebiopsy them. Okay. Interrupt me as we go along. I can't actually, actually I can see the chat. Yeah, okay.
That's an interesting point. I just on that case, I had a similar case, a lady in her 60s with, in James's recently ATN, minimal change. She was steroid responsive, but within about 4 days of being on steroids, she got central serous maculopathy from steroids and was losing her sight. So I had to stop the steroids, and I treated her with rituximab, and it completely resolved.
Yeah.
On the basis that she was steroid responsive, and I couldn't use, and was trying to induce remission quickly rather than relying on the CNIs. She has single kidney as well, this lady.
Right. So, I mean, in the UK, we have a slightly crazy situation, which is that if you're under 18, you're allowed to be treated with rituximab for minimal change disease or FSGS causing nephrotic syndrome. But the minute you turn 18 and 1 day as an adult, you're no longer eligible for it. So we've had to kind of beg, borrow, steal to get rituximab for some of the adults. But as you say, it can work extremely well. Okay, so here's a second one. This is a woman, young woman, who turns up in casualty with some sort of non-specific symptoms, or a number of different symptoms rather. So some abdo pain, diarrhea, and feeling just absolutely washed out. And she'd had a previous very vague sort of macular rash on her chest in the previous week, but otherwise had been completely fit and well. She was originally from Eastern Europe, been living in the UK for a number of years. And the highlights of her investigations are here. So the questions always remain the same. The questions remain the same. So now that we're warming up, everyone's had a drink. Oh, maybe you haven't had a drink, it's 3 o'clock in the afternoon. Now that you're warming up, what do you think about the story and the investigations?
So Liam and Fergus, you're up. Microphone not working.
Well, you can type, can you?
They are typing, yeah.
Oh, are they? Okay.
Just while they're typing, actually, Alan, Bowman had a question about rituximab in adults for minimal change. Why isn't there been a trial?
I mean, I think the, I mean, it's a good point. There should be. I think there's a, with a lot of, I mean, it'll be a theme we come back to. With the glomerular disease, there's a lot of movement to try and stop using such high dose steroids. And so I think in a sort of iterative trial basis, the next study might be to do something like a 3-way trial comparing steroids, TAC, and rituximab, or even TAC and rituximab, just to see what the likelihood of response is. But I don't know is the answer. There isn't a good reason why there isn't a trial. I mean, we've only just got trials of rituximab in membranous, where again, it makes a lot more sense because there's a circulating antibody. So I think it will happen, but it's just taking a bit of time.
So Liam and Fergus are, looking for HSP.
Okay.
And they've got a kind of a query lupus ANCA HUS.
Okay, so we're covering a lot of bases here. Let's see. What about the, so it might be hard in terms of typing, but let me ask you these other questions then. So we've got HSB, we've got Anchor, and you said, what did you say? What was
SHUS.
Okay. So it's Friday and it's 5 o'clock, and this patient has walked in your department. Okay, so what about LDH and a blood film? Okay, very good question. So what are you thinking about with LDH and a blood film? In fact, I know what you're thinking about. You're thinking about HUS, which is a good thing to think about. So you're thinking about whether they've got a thrombotic microangiopathy, which explains the thrombocytopenia and the anemia and the renal failure. Okay, so that's a very reasonable thing to do. What do you think about doing a kidney biopsy? So not bloody diarrhea, but diarrhea, unless you're swearing, in which case bloody diarrhea. But yeah, no, just diarrhea. Do you want to do a kidney biopsy? Does anyone want to do a kidney biopsy? Let me throw it open. Would anyone?
This is a poll, so you type in yes or no now.
Need more data. Okay.
Laura and John, yes. Iophy, urine dip.
Okay, Aoife, I like that. Urine dip. Beta HG.
BHG.
Oh, beta HCG, pregnancy. Not pregnant, good question. These are all good questions. So urine dip, 3+ of blood, 3+ of protein. Diarrhea, definitely. And I think the investigations you've all suggested are very good. LDH and a blood film, which you can get straight away. So I'll tell you that the LDH was elevated, and I'll tell you that the blood film showed some fragments and some schistocytes. And I'll tell you that we would normally not biopsy such a patient, but there are some circumstances when we would, and in this particular case, we did. Here's one glomerulus. Here's another glomerulus on the right. And here is a bit more of the kidney. I don't know how much you guys like or dislike pathology. If anyone wants to jump in, you can.
They love pathology.
They love pathology. Okay, so let's talk about some pathology. Anyone want to tell me what they think about this high power?
Tammy particularly loves pathology.
So Hannah, quite right. You wouldn't. Part of the reason why we wouldn't biopsy them straight away is because of the hematological abnormalities. And in fact, it's you definitely don't want to stick a needle into somebody who's got a platelet count of 66 and a hemoglobin of 6. So you would have to correct those first. The question is whether you need to correct those first before making a diagnosis. We'll come back to that in a second. So
Tammy, what do you think?
So, Tammy, first question: do you think it looks normal or abnormal?
Abnormal.
Very good. And where in the glomerulus? What is the abnormal? What can you see in terms of the abnormality? Can you see normal capillary loops, nice open capillary loops?
No, there's not normal open capillary loops, and
Okay.
maybe the mesangium looks like there's deposition there as well.
What is there instead of open capillary loops? So here's one open capillary loop at the top, if you can see that. But if you look around here, as you say, you can hardly see any open capillary loops. And what's going on in this? This was a capillary loop. What can you see within the areas that were capillary loops?
TMA?
Yes, you can see some fibrin, you can see some clot, essentially. Here you can see so here's an arteriole, here's a small vessel as well. remember, capillary loops are small vessels as well, and within these you can see them actually being filled by microthrombi, and you've got some fibrin deposition in and around there, and you can see that this vessel would normally be completely white, the lumen would be open, and you can see that there is a structure within it that is a reasonably well formed clot, and there's another microthrombus here. So there's evidence of microthrombi. There's some leukocytes within one or two of the capillary loops that have been attracted in. You can see some of these look like either fragments of cells or whole cells that might be that might be neutrophils. And here's another vessel that you can see, and here you can see the whole lumen. Here's the lumen down to this very small amount, which should actually be occupying nearly all of this. So evidence of microthrombi in the vessels, in the arterioles and in the capillary loops. And given that clinical picture, you've got a thrombotic microangiopathy. So what can we say? What's the illness that we would call this? It's a thrombotic microangiopathy, and we might give it another name. Tammy, what would you call it?
The Adams 13 result, Alan.
Yeah, we'll come to that in 2 seconds. I'm not ignoring you. I've seen that. So Tammy, would there be a name for this? A TMA with renal failure.
Anybody else want to jump in there?
So we might call this might fit for a hemolytic uremic syndrome, right? So they've got renal failure and they've got evidence of TMA. But TMA isn't just HUS. Is there anything we can say about the HUS given this clinical history that you heard? Anything you might want to ask?
Maybe atypical because there was no bloody component to the diarrhea.
Say that again. Sorry, I didn't hear it all.
Maybe atypical HUS because there was no bloody component to the diarrhea.
Okay, so you make an important point, which is about 50% of patients with atypical HUS will present with diarrhea. So diarrhea alone isn't a very good diagnostic tool in terms of separating whether this is diarrhea-associated classical HUS or whether this is atypical HUS. There are some other things, so a bit more biopsy material. Again, you can see a vessel which has got quite a lot of thrombus within it, and then a very large vessel here, which you can see has got the lumen narrowed right down to this small amount, and there's a lot of material occupying the rest of the vessel lumen. So diagnosis, we've got an anemia, we've got a thrombocytopenia, and we've got renal failure. So we've got a thrombotic microangiopathy. The blood film shows you some schistocytes and some fragments, and that confirms that there's a microangiopathic hemolytic anemia. And then the question is, what's the cause of this? Okay, so as often is the case, these things happen when you need to start thinking about the management straight away before you can get all the investigations. The most important thing to do is to make sure that you send the blood off immediately so it can be processed for Adams TS13. Because once you start any other therapy, you might lose that diagnostic utility of the test. So we have had people who've tried to send tests off after patients have been plasma exchanged, and obviously that's no use whatsoever. So you send the test, even if it takes a bit of time to come back. There are some diagnostic scoring systems that are based on some of the biochemical parameters and some of the symptoms that give you a clue as to whether it's more or less likely to be TTP than HUS, but they're not absolute, and there can be a lot of overlap between these conditions. TTP tends to give you a bit more neurological disease and maybe not so often giving you kidney disease, so we tend to see slightly less of it. But both of them can present with neurology, with cardiac involvement, and with kidney involvement. So in all of those cases, in all the cases of thrombotic microangiopathy, the essential problem is that the endothelium, the lining of the blood vessel, is activated. It becomes procoagulant. As it becomes procoagulant, complement activation occurs, platelets get deposited, and you get a microthrombus, which causes an occlusion of that small vessel. And as the red cells try to wriggle through that clot, they get broken up and torn apart. And that's why we see schistocytes, and that's why we see red cell fragments, because the red cells have been pushed through essentially a sieve of clot. So you get evidence on the blood film, and you get microthrombi in a number of different blood vessels. And then you just have to think about the causes. So there's a long list of causes, and some of these things are slightly more obvious than others. So we briefly spoke about HUS and TTP. Lupus can definitely do it. Antiphospholipid can do it. Systemic sclerosis, you would think you might get some clues from the physical exam and from the history as well. Preeclampsia should be reasonably obvious from one or two other clinical signs you might pick up. But don't forget drugs, chemotherapy, certain drugs that we use in other conditions. And obviously there is an element, some of this is certainly related to the HUS, maybe a genetic component that triggers it. So defects in the complement pathway. In both TTP and HUS, you can either have a genetic predisposition or you can have an antibody to the component that's important. So Adams TS13 stops platelet aggregation occurring, whereas so you can get antibodies to Adams TS13, or you can get a defect of Adams TS13, a genetic defect. And similarly in HUS, it can be something that activates the endothelium. So that's classically a sugar toxin in the diarrhea cases, E. coli, or sugar, another sugar toxin producing it. Sometimes pneumococcal infections can do this as well. It's pretty unusual. And then you can get abnormalities in the complement pathway, and I'll just show you that horrible picture in a second, which kind of shows you that the alternative pathway of complement is normally always switched on, and you've got a number of natural breaks that stop that overwhelming activation. So they're things like factor H, factor I. And if you have a deficiency in factor H or factor I, or you have an antibody to factor H or factor I, for example, you will have unopposed complement activation, deposition on the endothelial surface, and generation of coagulation cascade, and then the formation of the microthrombi. So I always think about this a little bit like driving an automatic car where you have both the accelerator and the brake on at the same time. So the brake is the factor H and the factor I, and the accelerator is the turnover through this alternative pathway that occurs all the time. And that's fine. It's in balance if you apply the same amount of pressure to both. The minute you lose your brake, you've got unopposed acceleration, and that's why this gets deposited on the endothelial surfaces. And then you get the downward cascade forming the membrane attack complex, and you get some of the tissue damage. So traditionally, the treatment for this would have been plasmapheresis, trying to remove an autoantibody to factor HI or Adams TS13, and introducing normal plasma that would have normal levels of complement regulatory proteins if they are deficient due to a genetic cause. Since the introduction of eculizumab, plasma exchange may not be necessary as the first line if you can get hold of eculizumab there and then. But the important thing to remember is in this differential, and one of the things that I forgot to add here, which is very important, sorry, is accelerated phase hypertension. And so you can get a very similar picture of a microangiopathic hemolytic anemia, thrombocytopenia, and renal failure in people who have severe accelerated hypertension. And it's very difficult to know late in the evening when patients present whether this is actually a presentation of atypical HUS or whether this is simply very, very severe hypertension due to some other cause, whether it's a primary hypertension or whether it's a renal lesion like IgA that causes severe hypertension. So you have to try and look for other markers that suggest that this might be primarily a hypertensive problem. LVH, look for signs in the eyes, for example. Look to see if there are other features elsewhere in other vascular beds that that might be going on that might suggest it's more likely to be TTP or HUS. You have to treat the hypertension aggressively, so you have to make sure that that is well treated. And then you have to make a decision about whether you would blindly treat till you can get some of the other investigations back. You would hope that you would have you'll send your autoantibodies off, you'll send your complement levels off, you'll have a look to see if there's any other antibodies that suggest there might be a systemic sclerosis, or if there's any clinical examination that would fit with that. But you're often left with this indecision about whether this is just very bad hypertension causing a TMA with some underlying process driving that, or whether this is an atypical HUS and something else going on. And we've certainly plasma exchange people who have turned out to have hypertension, and sometimes we've just treated the hypertension, and then within 24 hours it's become apparent that things are not generally going in the right direction. We've initiated plasma exchange or eculizumab. In terms of if it's hypertension driving it, what we normally see is that the platelets will start to recover within 24, 48 hours of treating the hypertension. Whereas if it's an HUS or a TTP, treating the hypertension will not get an improvement in the thrombocytopenia or in the anemia. So eculizumab is I think I've said most of that. Eculizumab is out there. There's also a new version of the C5a inhibitor, which is a long-acting version of eculizumab, which now can be given once every, I think, either 4 or 8 weeks. So a huge advantage in terms of patient compliance with it, because they don't need to come up every week to have it done or give it to themselves every week at home.
Question, Alan, about vaccination from Beaumont.
Yeah, so of course, if you are to initiate eculizumab, they need to have certain vaccines, as you say. You need to have the meningitis vaccine. If you can't get that straight away, then you certainly need to cover them with antibiotics, and we normally use ciprofloxacin to make sure that they're covered for 2 weeks while the vaccination goes in, and you can start the eculizumab. Now, again, it depends on how easily accessible it is for you. We can get it reasonably quickly, so we can make a phone call to our, we've got a national centre that decides on dishing out eculizumab, and we'll present the case to them. We'll send them the DNA to do the genetic analysis. If they agree, I mean, obviously the DNA analysis will take about 4 to 6 weeks to come back, but if they agree with a clinical scenario, they'll release the eculizumab, which many of the hospitals will have anyway, and we can start treatment within 24 hours. And we've certainly had some major successes where we've started it very rapidly, and people have come off dialysis and have had their renal function improve within a matter of days. So the sooner you start it, whether it's plasma exchange or whether it's eculizumab, the quicker the recovery from the renal failure. And it's a very difficult decision, and I think personally, I think you have to cover your bases. And if you think that plasma exchanging them over, if it's a weekend and you really can't make your mind up whether this is simply hypertension, and there aren't enough clues that this was long-standing hypertension that has now become accelerated, then it's best to plasma exchange them, best to give them some eculizumab, and then think about the diagnostic certainty afterwards, because the worst thing you can do is just treat the hypertension and not do anything else.
How long do you continue the eculizumab for?
Brilliant question. So nobody knows, but there are trials going on at the moment where people are trying to withdraw eculizumab after a while and see whether people can get away with it. There was one very interesting study that was done in transplantation in people who ended up with irreversible renal failure due to HUS, where we would normally initiate, at the time of the transplant, we would start them on eculizumab to prevent them getting a recurrence. And there was one study that looked at not giving everyone eculizumab, and there was 6 patients, many of whom did not get recurrent HUS. So the fact that it was the cause of your renal failure in the first place does not mean you will definitely get it back again. But we would have a very low threshold for reinstituting eculizumab if something started to go wrong with the transplant early on. But it's a brilliant question. I mean, the drug company wants you to use it forever and ever. We would, we don't know the answer, but there are trials ongoing about a withdrawal of eculizumab to see how many people still need it, and whether there are some in vitro tests that we can do to try and assay whether they still have membrane attack complex formation when you stop the eculizumab. Okay, so HUS, TTP, thrombotic microangiopathy, you have to think about all those other conditions that might be causing it, because we've certainly seen people with very bad lupus who present with a TMA, and actually treating the lupus in conventional methods is the way to, and the hypertension treats the TMA. Do you need to give Plex if you can give eculizumab that night? No. So it's one or the other. And I think it basically depends where you are and what access you've got to these two. I would say that if you can't get hold of eculizumab and it's the weekend and you don't have facilities to do it, that you have facilities for plasma exchange, or you can refer them into somewhere else, that's what you should do. And if you don't have the Adams TS13 result. So we're very lucky. We have a hospital down the road that does Adams TS13 assays within 24 hours, but I think that's really, really unusual. And I would say you have to treat it based on the clinical phenotype. So if you've got somebody who's got neurological disease and renal failure and they've got a TMA, then you have to have a very high suspicion that they've got TTP, and then you would plasma exchange them. But you won't get the Adams TS13 result back, you know, in enough time generally to make that decision for you. Okay, so it covers quite a lot, this. Happy? All right. Okay, so this is more about a sort of management issue rather than the pathology itself. Say again? Yeah. Yeah, I think it was a viral infection. Sorry, I'm getting questions from the audience here as well. So Sally was just asking about the rash, and I said that I think, remember that most of these people are heterozygous for the mutations when they have the genetic abnormality, and so there is thought to be a second hit that you need to trigger this, whether that's a drug or a virus or another non-specific infection or a pregnancy that is enough to initiate endothelial activation and damage that then causes the clinical manifestations, because a lot of these people present later on in life, and so just having the genetic abnormality does not necessarily mean you're going to get it straight away. Okay, so here is a 22-year-old who's referred to the clinic with proteinuria and renal impairment. And when she comes to the clinic, she says to you, I must also tell you that I think I'm pregnant. I think I'm about 3 months pregnant. And sure enough, she is. So you send off a beta HCG, you get an ultrasound and confirm she's pregnant a little bit earlier than she thought. And those are the readings that we've got. Creatinine of 130, albumin of 23, and a UPCR that was quite elevated at 560. And she's got blood and protein on the urine dipstick. So what do we think? Fair to say there's a wide differential here, and it's difficult to know just on that basis. I mean, this could be a number of different renal lesions that are doing it.
Well, what do you think?
So must have baseline. Well, presuming she has baseline CKD, serum creatinine 130, you'd expect it to be lower than that. Even if you allow for dilution with pregnancy, that's an abnormal creatinine.
Yeah, an AKI to pull as well, yeah.
Yeah, or an AKI. So previous baseline bloods would be helpful there. Low albumin is probably lower than you'd even expect for pregnancy. So again, and that corresponding with a nephrotic range of proteinuria suggests that she's a nephrotic syndrome and she's an active urine. So differentials would be possibly maybe, an IgA. What else could give an active? You can get an active. You can see blood in mineral change, but it's not that common. At 22, vasculitis would be unlikely, but it's way too early for preeclampsia. But What else could it be? Maybe a TMA picture. If we look, if she was very anemic or she had low platelets, or a TTP picture, but again, be atypical. That's
Okay.
Someone's wondering what race she is.
She's black. Does that increase your change anything?
an FSGS picture as well.
Okay. All right. Okay. So those from DNA. Okay. Any prior miscarriages or prior pregnancies? No. First pregnancy. No prior miscarriages. So your wish is my command, as they say. So we get some bloods back. She's seen in the clinic. We get some bloods back. It shows that she's got an ANA. She's got a double-stranded DNA, which is way off the scales, and her anticoagulation is negative. She's got an anti-Rho, and in this particular case, she's ANCA negative. She has got a low C3 and a low C4. So I skipped over, but what do we think about doing a kidney biopsy?
Vote now, yes or no.
Mark desperately wants to use the technology. Yes, yes. Okay. Everyone, unanimous. Wow. This is a bit like the Eurovision Song Contest. Everyone's giving me the 10 points. Okay, so what would be the reason not to do what would change your mind about doing the kidney biopsy?
Very good, Beaumont, I like it.
I think you've been indoctrinated, Beaumont. Why would you not do a kidney biopsy? What if she presented 10 weeks later? 5 weeks later? Have you got a cut-off in your mind about when you would be happy to biopsy a pregnant woman? So I think the answer is you can biopsy for a while. It obviously becomes more problematic the later during the pregnancy. But certainly at this stage, at 10 weeks, at 12 weeks, really up until about 18 weeks, 20 weeks, we would be happy to biopsy them. So we did go ahead and biopsy them. Her. This is one high power of the glomerulus. I'm just going to show you that this is another glomerulus. This is a silver stain, as you know. And that is a EM picture. Does anyone know what that is? You all know what that is. So this is very good. So tubular reticular inclusion. Just to save a bit of time, this shows very beautiful reduplication with tram lining or double contouring. You can see the silver picking up the outer aspect and the inner aspect of the basement membrane, so really beautiful. So when you see this, you think about something that is sitting between the endothelium and the basement membrane. And so the question is, what is that? Is that, you can see this in antiphospholipid syndrome, you can see it in transplant rejection, and you can see it if you get antibody deposition. So what you really want to know is whether there are deposits, subendothelial deposits, that explain this. And here you can see very, very thick, this is the sort of H&E picture that you would see associated with that, very, very thick capillary loops. Really, really, in some cases, I think when I saw this earlier on, I saw some actual double contours on the H&E as well. So this is this would give you a clue when you see this sort of appearance on the H&E or on the silver, you'd think about whether there are significant immune complex deposits. You can also see on this part of the biopsy that there are some extracellular, extraglomerular cells. So she's got the beginning of a crescent forming here, and she's got a tubular reticular inclusion. And this is her EM. So here is the lumen. Here is the basement membrane, and you can see that there are massive subendothelial deposits here along this aspect, and there are also some subepithelial deposits sitting underneath the podocyte foot processes, some slightly more obvious than others. So she's got, and if you look around here, I don't know why I'm pointing at the screen, but anyway, if you look around here, there are some mesangial deposits as well. So she's got deposits in the mesangial area, in the subendothelial, and in the subepithelial area, and that's really pathognomonic for lupus. That's where you get all three sites with deposition. So she has got lupus, and she is 11 or 10 weeks pregnant. So what are we going to do? What are you going to do? You're the boss, and all the phone lines are down. Mark Little is not available.
Not that I'd be any help on.
What is the patient's thought on pregnancy? Okay, so it's a very good point, and that's something you need to discuss, obviously, with them. When we discussed it with her, she was adamant that she wanted to carry on with the pregnancy. She did not have any pre-pregnancy care. No counselling. She was not. I mean, this was an unplanned pregnancy, and but she decided that she wanted to keep it.
So Hannah, you've done a bit of stuff with Dr. Wall, yeah? What do you think?
So kind of the basics, I suppose. You definitely want to put her on high dose folic acid. You'd want to make sure her blood pressure was well controlled. You'd probably put her on aspirin because she's at an increased preeclampsia risk. And you'd want definitely for her to be on Plaquenil and then to decide about immunosuppression. So obviously MMF is not going to be safe in pregnancy for her. So maybe you'd consider something like a calcineurin inhibitor, or I don't know, would you go with rituximab? Maybe not in the midst of the pregnancy. Okay, very good. So kind of summarizing what you've said,
at this stage of the pregnancy, cyclophosphamide and mycophenolate are out, so we can't use those. You can use steroids, you can use azathioprine. We use that a lot in our pregnant transplant patients. You can use hydroxychloroquine, obviously, and you can use CNIs, whether that's TAC or cyclosporin, depending on your preference, and you can use IVIG. Rituximab is slightly contentious. So the problem with rituximab is that once you get to 17 weeks, if it's still hanging around, it will cross the placenta and can cause neonatal B-cell depletion. And we don't really know, I mean, there have been cases where it's been used. We don't really know the long-term effects of rituximab and B-cell depletion on the fetus later on in life. Certainly immediate outcomes are reasonable, but it's the long-term consequences of that we're not going to be completely sure about. So I think that you're right. You do all the other usual things. You treat, you make sure that the blood pressure is okay. You treat with folic acid. You give aspirin because of the risk of preeclampsia. You would start on hydroxychloroquine. We've had about 3 or 4 cases which are very similar now. One who we thought had lupus because she had a circulating anti-Ro, but also had an anchor, and actually when we biopsied her had much more of a porcine-immune GM. And we've done the same thing in all 3 of them essentially, which is that we've used a combination of steroids, azathioprine, tacrolimus and hydroxychloroquine. And we've been lucky that most of them have responded, their renal function has stopped deteriorating, although some of them did go up a little bit more than this, and they've delivered healthy babies for the most part, although some of them prematurely. And then after that, you have to decide about whether they want to breastfeed or not breastfeed, and then decide whether you can give them rituximab or cyclophosphamide at that stage. And it's very much up to, depends on what the biopsy looks like and how severe the lesion is. But certainly once you've got beyond sort of organ formation, in the third, in the third trimester, you could use cyclophosphamide. And that certainly is done instead of using rituximab, because cyclophosphamide has very little impact on the mother, on the developing fetus at that stage. There is something slightly emotionally difficult with giving a pregnant woman cyclophosphamide, so we've not tried that ourselves, but there are people who do that and suggest that if the renal lesion is bad enough in the third trimester that you can do it. But we've got away with the most part of using a combination of oral therapy, and sometimes you have to push the TAC level up reasonably high to make sure that you get the result you want. But it's quite hairy, and you're absolutely right. You do need to talk to the mother about what her feelings about the pregnancy are, because there is a high risk that she loses the pregnancy anyway as a result of the active GM, and it's important to know what her feelings about that would be. Anything else on that? So it's not uncommon, and as I say, it can be quite tricky. We tend to see them very frequently and monitor things, and are aggressive with blood pressure control and controlling all the other factors. And as long as you can get them to sort of beyond the, if you can get them out to 32 weeks or so, then you're doing a really good job, and you could then deliver them safely if things start to go wrong. Okay. I'll quickly do two others, and then I'll do one other quickly, and then we can see whether we've got time to do another one. So this is a 79-year-old man who presented with classical nephrotic syndrome and was found to have just over 5 grams of proteinuria, low albumin, but had preserved renal function with a creatinine of 80 when he first presented. So we've gone through the differential of that. I'm not going to draw that out from you. He underwent a biopsy. This was pre-PLA2R, and you can see on the silver stain on the top left, really beautiful spikes there, which are really formed by the immune complexes that cause extra deposition of the basement membrane. You can see the granular IgG staining, and the C3 staining was similar. And on electron microscopy, as we've shown already in that lupus space, you can see really nice subepithelial deposits all the way along. So membranous, nowadays obviously we'll do a PLA2R antibody test to see what's going on. 79 years old, so you'd want to screen for malignancies depending on what you think is appropriate for his age. Some places would do a CT scan, send a PSA, think about, obviously sort of look at the chest, look at the bowel, to get some idea of what's going on. But he didn't have any features of malignancy. We didn't have a PLA2R on him. Nowadays we would do, and I think he was considered to have idiopathic membranous. Okay, he was not too bad in terms of his edema. He was treated with diuretics and ARBs, and as is sort of along the KDOQI recommendations, at least for the first few months, he was treated conservatively. He didn't have any severe features that meant we were worried about starting immunosuppression straight away. So he was treated sort of conservatively to see if he was one of the small number of people who might spontaneously resolve. Now, I think nowadays with PLA2R, that changes that dynamic a little bit, because we know that if you have very high titer anti-PLA2R antibody, you're less likely to spontaneously remit. But this was pre-assay. So he's sent away. We see him regularly, and then there's an extension of his conservative management that goes on. And 8 months later, he comes back to the clinic, and he looks pretty awful. He says he's been throwing up, and actually he admits that he's not really passed very much urine, or any urine at all, for a short while. And when we get his bloods back, it shows now a creatinine of 1400, an albumin of 13, and we get him in and we start him on dialysis straight away. It's the same 3 questions. Nephrology is so easy, isn't it? Just answer these 3 questions and you've got it all sorted out. So, what do we think about this?
I think Laura and John are the people who are next online. They're going to say they haven't got a microphone now, aren't they? Either that or they've gone off for a cup of tea.
Yeah.
Michelle, do you want to have a go? So Laura and John, differentials.
Okay, so worsening membranous, we've got Laura and John who've now responded.
Michelle, relapse of membranous.
Okay, so relapse of his membranous. And what, okay, good thought. I quite like this. So we've quantified his proteinuria. Let me do the things that I can tell you. So he's still got quite a lot of proteinuria. I can't remember how much, but it's nephrotic range proteinuria. His ultrasound does not show any evidence of a clot. So you're thinking about whether he's now thrombosed his renal vein, or renal veins, which of course is a strong possibility. But he's got no evidence of thrombosis in his renal vasculature. So in terms of, you've said relapse of his membranous, or worsening of his membranous, why the sudden change in his renal function? We've got malignancy-related hydronephrosis. Okay, could we have missed a malignancy of some description, and in fact he's got some sort of bladder, ureteric tumor, retroperitoneal tumor, sarcoma, lymphoma, something like that that's causing an obstruction. So let me, so kappa lambda stains on the original biopsy were unhelpful. There was no predominance of either kappa or lambda chains. So let me fill you in. He's still got nephrotic range proteinuria. His ultrasound shows, the Dopplers show no evidence of renal vein thrombosis, and he's got 2 kidneys that look unobstructed. So the question now is, what are we going to do? He's on dialysis, so we're going to make him safe that way. But should we do anything else?
Want to rebiopsy?
Rebiopsy. 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 Okay. So here's a low power. Here's a slightly higher power. If you all had buzzers, it would be quite exciting because you could buzz, and the first one to buzz would get a prize. There might be an incentive now. So here's the slightly higher power. Here's a silver stain, which is a really nice and very useful stain. So,
Beaumont, you want to have a go?
Can we get a PLA2R now? You can. It's negative.
What's Beaumont's view?
So Beaumont says crescents. Okay, so here's the low power. You can see the reason for showing you this is just to highlight something that's quite important. So you can see that a number of the glomeruli, in fact, all of the glomeruli look pretty abnormal. You can see there are, yes, indeed, some interstitial, there's some interstitial blueness, which is a marker of inflammation, infiltration with some leukocytes. But the important thing to notice here is that all of the glomeruli are abnormal and they all look very similar, okay? So when we look at slightly higher power, you can see that in all of them there are some extra capillary cells present. So there's a crescent here, a circumferential crescent. Here it's not quite so easy to see, but there are some cells on the outside. Here the glomerulus is very severely damaged, but if you actually follow Bowman's capsule around, you can see that there's some necrosis, but there's also some cells here. It might even be a rupture of Bowman's capsule at this point. And just at the bottom of the picture, you can also see another crescent at the top surrounding that glomerular tuft. So we've got lots of crescents. And so you've got to think to yourself, when you've got a crescentic GN, what are your top 3 or top 4 diagnoses for a crescentic GN? when you've got large numbers of crescents, the order changes somewhat. But if you just think about, so normally when we talk about a crescentic GN, we're talking about more than 50% crescents. And if you look at diseases that have the highest number of crescents, it will change the order a little bit. So, so three things that I would normally think about. I'd think about anti-GBM disease. I'd think about porcy immune crescentic nephritis, which is for the most part ANCA associated. And then I'd think about an immune complex crescentic GN, and really much less common, but the things that you would think about would be either IgA with crescents, severe crescentic GN, or something like a lupus with crescents, both of which are associated with immune complex deposition. So the key to this diagnosis is really the combination of the light microscopy and the immunofluorescence, because the immunofluorescence, if it shows you linear IgG, will tell you this is GBM disease. If it shows you IgA, then it's IgA. If it shows you a full house of IgA, IgM, complement, IgG, then it's very suggestive of lupus. And if it shows you very little immunoglobulin deposition, then it's highly suggestive of a porcy-immune crescentic GN. So, and as those of you at Beaumont are saying, the fact that these crescents all look very similar, synchronous, makes us think more of anti-GBM disease. If there were some normal-looking glomeruli in the biopsy, then one would think about whether there was any other signs of mesangial expansion or proliferation that might fit with a crescentic IgA, for example. And if there were segmental scars in some of the glomeruli, or evidence of previous fibrocellular crescents, for example, but we might think about something like ANCA, where you'll get some crescents that are very fresh, some that might be a bit old, some glomeruli that might look normal. So a bit more of a mixed picture. And on the basis of, on the light microscopy, which is what we've got here, so lots of crescents, which look very similar in terms of age, and on the silver, really emphasizing that again, very severe crescentic nephritis. And here you can see a really beautiful picture that, that shows the compression of the capillary loops and the glomerular tuft. And you can just imagine the reason why this becomes an RPGN is that there's no amount of hydrostatic pressure that is being pushed through these capillaries that will enable you to have any filtration at all. I mean, that Bowman space is completely filled with inflammatory tissue, and so you can't filter anything through this, and that's why your GFR goes down to almost nothing. And then sometimes on the silver stain, you can actually see breaks in the basement membrane. I can't actually see one here, but it shows you how the crescent actually forms in the first place. Okay, so here's just some highlights. You can see this is immunoperoxidase on the right rather than immunofluorescence, and you can see very pretty linear IgG staining, which is consistent with anti-GBM disease. So this is membranous GN with then secondary anti-GBM disease. By the time the guy had presented to us and when we got the diagnosis sorted out, we discussed immunosuppression with him. He was 79 years old. He really didn't want to go down that route. And to be honest, given the biopsy findings and given the history that we'd had, it seemed unlikely that he was going to recover his renal function. So he started and remained on dialysis. So just to quickly run through that, GBM in terms of other renal lesions, so associated with ANCA, often with MPO, associated with membranous. I'll show you a little bit about that in a second. Some cases associated or following the use of lithotripsy for renal stones. Obviously recurs in renal transplants in which there is a all ports phenotype when they get transplanted. And you can sometimes see linear deposition, but you have to be careful. If it's in association with diabetes, you don't normally get crescentic changes. You can get antibodies deposited on the GBM, but you don't normally get the crescent. And in all of these conditions that are associated with anti-GBM disease, you've got to remember that the theory is there is damage to the basement membrane, which then allows exposure of the alpha-3 or the alpha-5 chain of the collagen, which then allows an autoimmune response. That's what we think. It may be that there are other things going on, but certainly with membranous GN, with ANCA, and with lithotripsy, we think that there might be damage to the basement membrane and exposure of the antigen. In terms of crescentic membranous, it's pretty unusual. It does occur. It can occur, obviously, in the context of lupus. But most of the cases, when you look, are associated with a secondary or a primary anti-GBM disease. And there are some cases and some case series where it's associated with MPO. And if you see somebody who's got an ANCA vasculitis and they've got nephrotic range proteinuria or nephrotic syndrome, then you really have to think about an associated membranous glomerulonephritis over and above the porcine immune GN that they get with the ANCA. There are reports of membranous GN and anti-GBM disease. This is a slightly older slide. I think there are more cases now in the literature. But the interesting thing is that some of them occur synchronously. So the membranous, the nephrotic syndrome, and the anti-GBM present at the same time. Sometimes the membranous precedes the anti-GBM, and that's why there's this idea that it's damage to the basement membrane. But the two processes can be very closely linked. And so if you see somebody who's got membranous, who suddenly has a rapid decline in their renal function, you have to really think about whether they've got a secondary GN, especially anti-GBM, that's causing that. Have we got a few more minutes just to do one last case? Professor Little? Yes, no?
I think we do, yeah. I mean, we've been going 2 hours, so...
do you want to stop, or do you want to do a... Tell me, have you got something else lined up?
I don't know, no.
Well, you guys decide. How long would you wait to consider for transplant?
More case, fire on, they'll...
Okay, so just on the transplantation, without any significant data, but we would normally say 6 months, and we would want that's 6 months of having no circulating anti-GBM antibody. The old data suggests very clearly that if you transplant in the face of circulating anti-GBM antibodies, you're likely to get a recurrence. So we tend to say from the time of anti-GBM antibody negativity, 6 months, and then they can be transplanted. And that's one of the rationales for using immunosuppression in people, even if their kidneys are gone, so they're on dialysis, they don't have lung hemorrhage, but if they've got a living donor, for example, who's very keen to donate, we might try and get the antibody titrated down rapidly so that they can actually donate in a shorter period of time. Some old papers have looked at the natural history if you don't treat it at all, and some people have antibodies that go out to about 2 years. So if you've got somebody who's got a living donor who's transplantable, you might want to get the antibody titer down quickly and so get them onto the transplant program. Okay, so this is the last case, and it's an interesting one. This is a bloke who has got no previous medical history at all, was selling and buying, trading in wood in Brazil, and went out one day on a boat. The boat caught fire, exploded. He jumped into the Amazon and got 30% burns on his arms and his legs. He was in a hospital in Brazil. They did a really good job of looking after him. He clearly had documented rigors on 4 occasions and was treated with antibiotics. He got repatriated back to the UK, went to a plastic surgery unit because they were thinking about doing some skin grafts to his arms and legs, and noted that he was persistently hypoalbuminemic. He had peripheral edema, and the question at that point was, is this due to his burns and his loss of protein? And it was only after they asked a nephrologist to go and see him that it was realized that actually he had a degree of renal impairment and a slightly low serum albumin. Now, just for the interest of time, have a think about what you think this might be, but just to speed through it. These are the investigations, so slightly low complement, no evidence of another immunological abnormality. ASOT was not elevated. His virology was all negative. His syphilis serology was negative. He had a slightly low IgG. No paraprotein, no serum free light chain that was detectable. And then over the next couple of weeks, his creatinine started to go up, rose to about 174, progressed actually at one point to reach a sort of peak of around 300. So immunology was not particularly helpful, and we couldn't really understand what was going on. So we proceeded to a biopsy. And I'll show you
before you do the biopsy, I think.
Say again?
A couple of comments.
All right, sorry. LFTs were normal, so lepto is a very good idea. No evidence of lepto. Nothing grown on cultures of his blood or of the urine were at the time. He was treated empirically with Cipro. I can't remember whether he had schisto scent. I can't remember if he had schisto scent, to be honest. Dipstick showed blood and protein. So it's slightly the wrong way around, but I'm showing you the biopsy. Anyway, here's the biopsy. Low power on the left, high power on the right. Very high power of the glomerulus here. And then this is the EM. So, anyone want to have a go at this?
Hannah, are you feeling confident? I'm picking on you, I'm sorry.
So the glomerulus definitely looks like there's increased expansion, so maybe increased mesangial expansion.
Yeah, so mesangial expansion. What about kind of the blueness of the glomeruli? So pathologists are always very vague. When you ask them what a mesangial area is, they kind of say, well, it's an area of mesangium. And when you ask them to define what that means, I get very vague answers back from them. So it's not completely clear, but normally mesangial hypercellularity, you'd think about more than 3 nuclei per mesangial area. So, I mean, I accept that that's a little bit vague, but if you look around, you can see areas where there seems to be too many cells within this biopsy. And also, I think what is reasonably obvious on this glomerulus is that you can't see very nice open capillary loops. And there certainly seems to be some areas where there might be polymorphs within what would be a capillary loop. So there might be some degree of endocapillary proliferation as well as mesangial proliferation. And when you look at the silver stain, again, which is very pretty, you can see some evidence of double contouring and tram lines. So again, when you see double contours, you really think to yourself, there's got to be something that is pulling these membranes apart and is being deposited there. And so when you look at the EM, I mean, they're so unusual that it actually gives you have to sort of stop for a second and try and figure out what's what. But in this bottom one, you can see here is the capillary lumen in the middle, and you can see this enormous, almost continuous subendothelial deposit, and then here a enormous subepithelial deposit that is sitting right underneath the podocyte. So this would be classically called a hump. So you've got subendothelial, you've got subepithelial deposits, and they are really, really quite extensive when you look along the EM. So And I think I think somebody mentioned MPGN. There is some degree of lobularity to this glomerulus or to these glomeruli when you look at them, and so it gives you the sort of suggestion that there might be a mesangial-proliferative glomerulonephritis. And so you want to do some other stains, and we did some IgA stain, and indeed there's really, really strong IgA staining of the glomerular capillary tuft. Not only mesangial IgA staining, but if you look at the high power, you also see some staining along the capillary walls, which explains, I think, why there is the subendothelial deposition that we see. So the IgA here, normally you might see mesangial deposition of IgA. When you see subendothelial deposition, that's generally associated with a reaction of the leukocytes, because they can bind the IgA within the capillary loop, and so you get this very proliferative lesion. And certainly in cases of IgA where you get crescents and or vasculitic type IgA, you often see capillary wall IgA deposition. So this is IgA with an MPGN, and I think all full points to the Beaumont crew. This is now something that is reasonably well appreciated, which is infection-related glomerulonephritis. So we talk about post-infectious GN, and of course, post-infectious GN, normally we think of as an immune response that develops to something like a streptococcus. That's why it occurs 10 days, 2 weeks after your sore throat or your pharyngitis or your tonsillitis. And you then get an immune complex formation that gets deposited in the kidney. There's no such thing, obviously, as a pre-infection GN, but this is really a glomerulonephritis that is associated with ongoing infection. Now, whether you can call this infection-related or post-infectious in his case, there are a number of reports now of IgA-predominant glomerulonephritis in association with infections, often in older patients, often in diabetics, often due to Staph aureus. And in some cases, there are there's evidence of complement activation, and there is evidence of a low C3. And whether some of these people who get a post-infectious actually have got some genetic predisposition in terms of the complement pathway, we don't really know. But there seems to be, if you were to draw a Venn diagram between sort of C3 GN and post-infectious, there certainly seems to be some people who have got complement-mediated abnormalities that persist beyond the post-infectious period. So maybe people who have some complement pathway abnormality, if they get the right infection, develop either an infection-related or a post-infectious GN, whereas other people who are exposed to the same sort of bug don't tend to get glomerulonephritis at all. And on the whole, the treatment of these infection-related GNs, especially the IgA-rich ones, are treatment of the underlying infection. With him, we could find no evidence of ongoing infection, and we could find, the skin had healed, he'd been skin grafted, everything looked very good. He'd had a complete course of antibiotics in Brazil. He had a second course of antibiotics when he was in the UK. And actually, whether it was the right thing or the wrong thing to do, I don't know, but we elected, because his renal function was deteriorating and because he had such a severe proliferative GN with immune complex deposition, we decided to give him some immunotherapy, and he had a very short course of steroids and cyclophosphamide, and having peaked at about 360, 370, his creatinine has settled down to about 120, 140, and he's been at that level now for a number of years. So when you've got skin infections in diabetics in older people and you get a progressive decline in renal function or an active urinary sediment and a MPGN type picture, have a think about whether this could be an IgA associated infection related GN. And looks like you've not only thought about it, but you've also had cases, so MSSA, diabetic. there was an interesting case series I saw from India where they tried to use steroids in people who had infection-related GN, and they showed no difference between patients who are treated with or without steroids. But I think it's very individual, and it depends on whether you've got a decline in kidney function and whether you think the infection is completely resolved before you go ahead and give anyone something that could make that worse.
No, and have they ever found the kind of Staph aureus superantigen in the actual lesions, do you know, or?
I don't think so, and it's not completely clear why in some of these patients it's IgA rich the way it is. It's not IgA unique, so I mean there is some IgG there, but like a normal IgA, there is more IgA than there is IgG. But no, I mean not completely obvious. I think the important thing is to try, as the Beaumont team have said, is to try and make sure that you've got no signs of active infection, and if you have treated whatever infection it is adequately and you think you've done as much as you can, if the renal function is declining, then partly dependent on whether you think the patient could tolerate infection, could tolerate the immunosuppression, then in some cases it's certainly been done. But there are some anecdotal reports where people have done very badly with immunosuppression in the context of an infection-related GM.
There was a case series in France too. You know, the distinction, like the Mayo Clinic SETI made this distinction between para-infectious and post-infectious. Obviously, para-infectious, you're often dealing with an infection that's going on at the same time. And there was a case series from France where it was all observational retrospective, much higher mortality in those who had steroids. But you know, yeah, that's the hard distinction. I have seen one or two cases like that too that were truly post-infectious. So the infection was completely cleared, but they had ongoing immune response to it. Just like you said.
Certainly in the past, we've certainly given people with post-infectious GN immunosuppression if their renal function continues to deteriorate. And I think, you know, the way I think about this is that once you've initiated that glomerular lesion, once you've got immune complex deposition, even if you stop immune complex deposition at that point because your antigen is no longer present, you've still got immune complexes that are causing neutrophil and macrophage recruitment and activation and damage to the capillary loops. And so it doesn't matter that you've removed the antigen, you've still got that ongoing process. And that's why there's a sort of rationale for treating with immunosuppression in some of those cases. But I think the main thing is just to make sure that there are no signs of ongoing infection if you can help it. Is there anything that separates it from bad IgA nephritis on biopsy? No. I think it's just the extent of the involvement. And obviously the subepithelial humps give you a suggestion that this could be a sort of infection-related, but no, not really. I mean, the reason why you get certain immune complexes deposited in certain places is probably to do with the antigen and the size of the immune complexes you form. Okay, enough.
That's great, Alan. Well, it's